Hello and welcome to tonight's edition of the Rural Doctors Programme. I'm Jerry Gannon. Thanks for joining us. Tonight our programme will focus on the management of wounds. But just before we begin, I wanted to mention that the August unit of Check is on wounds management and is available at GP Learning. The activity is worth 6 Category 2 CPD points, so it would be well worth doing that after the show while the information is fresh in your mind. Don't forget, this triennium for CPD points is coming to a close. To make sure you receive your points for the Rural Doctors broadcasts, please complete and return all evaluation forms no later than the 19th of November. In the studio tonight we have Beth Sperring, who's acting clinical nurse consultant for plastics at Royal Perth Hospital. Welcome along, Beth.
Thank you. And
joining her is Stewart Flemming, who's plastic surgeon from Fremantle Hospital. Welcome along, Stewart.
Evening.
And making a welcome return to the panel, Dr. Olga Ward. Nice to see you again, Olga.
hello, Jerry.
So we're talking plastics, injuries and wounds.
One of the first things I wanted to ask about was wounds that are created by doctors, which we seem to do rather well. Are there any real traps for unwary players?
Trying to wrap them up too much, I think. I think we tend to cover wounds up, and often it's better just to wash them, keep them clean and be able to see them.
I think a lot of the time the patients are desperately trying to keep the wound clean and dry because someone said clean and dry, and 2 weeks later they're still wrapping it up in a plastic bag.
They are, and they wrap the rest of themselves up as well, which means that their general hygiene is often compromised, and you find that they just get bugsy. They just, you know, they don't smell good when they walk in. It's just problematic. So really and truly they should be sealed within, what, 2-3 days?
Yeah.
So why not hop in the shower? Sorry.
Sorry, leaving them exposed is one thing, but what about climatic conditions? For instance, in the far north-west of Western Australia, where it can be, 42 degrees or something.
There was a really good paper from GPs in Queensland about, 3 or 4 years ago in BMJ, and I think they had something like 940 wounds, and half of them they covered for 2 days and didn't do anything to them, and the other half they washed straight away, and they found there was no difference at all between two groups. If anything, the group that was washed had a slightly lower infection rate, but it wasn't statistically significant.
Presumably the patients also felt a lot better being able to wash.
I think so. The other thing I'd say is in hands, you want hands to move by and large, and so any dressings tend to interfere with movement. And Beth and her team are really very good at applying dressings that allow movement. But generally, the more dressing you put on and the thicker the dressings, the less movement you get. And I think that's really critical in the rehabilitation.
Beth, patients often turn up at the GP after a hip or a knee replacement. They've got this whacking great load of staples in, and the suture line sometimes looks a bit gappier, a bit crusty. Yeah. Do you still take the staples out?
Oh, a colleague once said, he quizzed his students and said, when do you remove sutures? Similar to staples. And one said 5 days and he said no, and one said a fortnight and he said no, and one said, take a pick, 24 days, and he said no. He said you take them out when they're ready. So you've got to look at your suture line, haven't you, regardless of sutures or staples, and you've got to say, is there still exudate from the wound? Clean it, look at it, surrounding skin, infection, and maybe you take alternates out. And then come back 2 days later and take the rest out.
Yep. And if something's looking infected, would you prefer to kind of take your foreign material, like your suture material, out or leave it in?
Absolutely, absolutely. But where is it? What's your patient like? Are they going to come back in 2 days? There's a big picture there, isn't there, that you've got to look at, and you've got to have a level of assessment of your patient and their environment and the wound to go ahead, and sometimes...
Why wouldn't they come back in 2 days, Beth? Is it because they've seen how it's done, they can do the rest themselves?
Sometimes, and sometimes life just gets in the way.
The vicryls, the vicryl rapides, Dexon, those sorts of things, they probably need to come out because the bugs stick in the interstices of the mesh, if you like. Yep. Whereas with the monofilaments, we leave them in anyway, subcutaneously sometimes, and deep buried sutures often are monofilament. Yep. And I think they do better. But I agree with you on the whole, if you can get them out, it's probably the best thing to do.
Now, speaking of difficult monofilament sutures and deep buried sutures, practice nurse often comes up to the doctor and goes, oh, this patient's come in from the plastic surgeon and they've got, a subcuticular suture with a little end sticking out of the skin, and she doesn't know how to take it out. And I have to say that they don't teach doctors very much about fancy sutures. Stewart, could you maybe go through some of those more difficult sutures and tell us how to get them out and when to leave them in?
The subcuticular proline suture usually comes with both ends. Sometimes they're tied down, and sometimes they'll just be left and steri-stripped down. And you've got a wound that's a bit like this one here. You've got the wound coming along here, and where the dotted lines are here is where it's underneath the skin. And you've got the stitch coming out at the end. And the thing to do is give it a good clean, both ends. Give it a little tug to make sure that it will move through. And then pull on one end, trim it, and then go to the other end, grasp it, and then gently pull in this direction. Now, often the skin tends to sort of buckle up, pucker, and it can be quite sore. So simply putting your hand over it and pressing onto the wound as you pull it through slowly is a sensible thing to do. Occasionally it will snap, and if it does, it doesn't matter too much, because you just trim it off, pull it a little bit more, trim it off so that it retracts back under the skin.
So it's not a disaster if you've got a little bit of proline that's stuck in the skin forever?
Probably not. I mean, it may come out, as long as it isn't. Sometimes they haven't been put in properly and they catch, but usually the surgeon at the end of the operation will pull it at both ends to make sure it slides through.
Is there a degree of discomfort for the patient while you're doing this, Stewart?
Yeah, there is sometimes. But on the whole, it's usually done at around 10 days, 2 weeks, possibly 3 weeks, and by that stage they come out very easily.
We should point out, Olga, of course, that this that Stewart is holding is his own artwork. He drew these himself.
Original watercolours by Flemming.
Absolutely.
This is because I wasn't able to get hold of any pictures of them. But then the other one is sometimes you've used a buried suture, which is an absorbable PDS, monocryl, something like that. It's been tied in the wound at one end, and it goes all the way. And then at the other end, it's easier just to bring it out of the wound and tie it in line with the wound, so that any stitch mark that it leaves just looks like a continuation of the wound. And what you see there is generally a stitch going through the skin, and then one that's obviously going underneath and towards the wound. And if you just pull on them, you'll see which one it is. Cut one, take the stitch out, then pull on it a little bit and trim it so that it slides back underneath the skin.
So this is something that's an absorbable. Normally the information that's supposed to come from the hospital or the surgeon will tell you
what it is. And it's difficult to tell sometimes which is which, but as I said, if it's proline, it doesn't matter too much if you were to leave it in. Sometimes there is a continuous over and over stitch. Eyelids, very thin skin, so it's difficult to do a subcuticular suture. And so what I usually do is I tie it over an artery forceps, there's a little loop, and then just run along. And then you've got a loop at one end that you can snip with a pair of fine scissors, and then just snip little bits in between and pull out the bits in between. Again, a little bit of pressure on the wound sometimes. You don't want to pull out too many because it's sore, as you say. And with these things, always warn the patient, like any suture removal, that you can sometimes get infection afterwards because you've got a hole going into the skin, you've pulled a stitch through it, and so tell them if they get a sudden flare, then come on back. And then finally the mattress sutures, the vertical mattress, which goes through the skin close to the wound, out, and then a big deep bite round. And with these, difficult to know where you snip them so that the bit of the suture that's been on the outside doesn't come through. The skin is swollen and they're actually quite difficult to get hold of. And they're stuck in. So they can be a bit problematic. German surgeon I once saw actually used to leave a bit of stitch underneath as well as he went along. So you just lift up on that and then cut it, which is quite a nice idea. I don't do them often enough myself to do that. And then finally the corner stitch, where because you don't want to put a stitch across here, a stitch across there, and cut off the blood supply to this bit of skin, you go into the skin and you come underneath. So it's like part of a subcuticular suture. It goes through the corner of the flap and then comes back out. And the nurse looks at it and says, well, what's that stitch doing over there? And where it's at a corner or a T-junction like this one, where it's gone in through the skin, gone through the subcutaneous tissue there, or just under the dermis, in there and then out, and then it pulls the T in together.
The thing is not to panic if you get a little bit of suture left behind, for starters. And I don't know about Stewart, but I teach the nurses if there's a bit of suture left behind, don't get excited, because I've seen people actually go foraging for sutures and therefore dehiss suture lines in doing so. A bit of stitch left behind, just leave it, get your patient back. In a day or two, look at it again if necessary. Check with the GP when they're back on call. And if you've got a suture that's supposed to be dissolving, make sure that all of it is underneath the skin. Because all it needs is a little tag to stick out and you'll get a little staph infection often. Very painful and not very nice for your patients. So make sure that you pull them, cut, so that they shrink.
There's another thing on that
Inside.
actually, because where you've got the PDS sutures, they sometimes take anything up to 60 days, and you've trimmed it, and then a couple of weeks later, a middle bit of the wound starts to break down, it splits open, and it won't heal. And actually, if you go back in there, you can usually put on a pair of magnifying glasses or whatever, you just hook out a little bit of stitch, and you find it there. You just pull on it, trim both the ends off, and the wound then heals straight away.
Now, Beth, there's another difficult nursing thing that we often ask
Is
putting dressings on difficult bits. Noses, ears, elbows, knees, eyelids. Suggestions?
there are ways and there are means. If it's on the face, seriously consider not even putting a dressing on it. Emollient, do you like emollient and Vaseline?
It's
a fave. I know. You've got to just use enough.
Wipe it off.
Correct. Yeah.
So just a thin skin of it.
A thin smear. You don't want to smother or make your wound soggy. You want to keep it clean and supple. Supple is the word.
See, I'm thinking about places like Port Hedland, for instance,
Oh, absolutely.
where the iron ore dust is constantly in the air.
Yeah, just
end up with a nice crust of Vaseline with iron ore coating.
No, they've got to do it 3 or 4 or 5 times a day. And once again, you've got to look at your person and you've got to say, are they actually going to have the skills, the ability, the resources to do this? And if they don't, then something quite simple is a very good idea, and micropores quite nice for faces. Retention dressings like Fix-A-Mol and Hyperfix and Me-Fix are great, but they're white. We were taught never to put white sticky tape on faces. We were taught pink micropore because it was aesthetically pleasing. The young kids these days don't seem to mind so much.
I was going to say, some of them like to go out of hospital looking like a real patient with a very large pad over their
And
face.
sometimes it can be nice, can't it? Because it's in your face saying, I'm special, treat me nicely.
Look after me and no housework for a week.
That's the one, you see. Kalgoorlie, they find the same sort of thing, particularly when they're blasting up there.
That's right.
And the girls up there, when I say to them, look, if this guy was in Perth, he would have a little bit of emollient on his graft and nothing else, and they say, can't do it. So they use a non-adhesive pad and some form of tape that's suitable for the patient's skin.
So when you are sending a patient home with the wound that is not... What are the sort of questions you ask in order to satisfy yourself that they can manage that wound at home?
The first thing I ask is, can you see this?
Can you see it? That's important.
Because that's important. Because often people can't.
Yeah.
And the nice thing about our telehealth service, plug for telehealth, is that when you see them in a week's time, you can say, well, tell us how you've been doing it. And they will tell you, and you put what you've told them and what they're telling you to do, what they're doing, and then you sort of just fill in the gaps and hope that you're pushing them in the right direction. Ears are notoriously bad, and the thing with an ear is a great big bandage on an ear is going to put compression on your ear, and so your little skin flaps are probably going to be at more danger than if you leave them with less dressing.
But the problem is they go to bed and they sleep on it, and then the following morning it's up here somewhere, and they kind of stick it back on,
and that's a real practical problem, isn't it?
Yeah,
it is. Pillow under shoulder at night. So, ear sick, pillow under shoulder, so that when you roll back, the pillow says to you, "Don't go any further." So you have your normal pillow, and then under the shoulder that's on the same side as the wound, another pillow coming down on your body, so that you roll over on that and you don't crush your ear. Arms and legs, there's nothing like a good bit of Fix-A-Mol.
Yeah,
really.
Stick right over a joint.
Stick it down. It's cheap, it's easy to use, it's simple, and it sticks. and it's really, really good. And then if you want some tube-on or some tubey grip or one of those bandages that are tubular in nature, I keep away, and it's a really, I don't know about you, Stuart, but I hate the one that's netting. Have you seen the netting? The worst thing you can do is put it on someone with a diabetic foot. Their toes go through the mesh, and the mesh cuts their web spaces. And it can also happen to our hand injuries where they've got sensory deficits in their hand as well. And they don't know until you come back. And the business of taking your tubular bandage and bringing it off, twisting it and shoving it back down again is very bad for our split skin grafts and flaps to fingers and, you know, digits in general, because once again you're putting pressure on top of a flap or a skin graft where it's not required. And if you're patient, and we've got some really stoical people out there, particularly in rural land, and they won't come near a GP or their nurse unless they really have to, and they will put up with the pain, and when they come back, that's when you find that their little flaps die or their skin graft's gone to heaven.
Okay, so if you're trying to do something, say a patient's had a digit terminalised, which is a very common thing for people to do in rural land, and they've got a little sort of advancement flap on the end of their finger.
It's pink, it's healthy.
And it's looking good.
Excellent.
How do you bandage up their finger?
Well, what you do is you get a piece of Fix-A-Mole. Make sure the stretch is in the right direction.
Yep.
You stick it on that side.
Yep.
You stick it on that side. So you fold it over like that.
So you don't need a pad over it or anything?
Nope.
No.
And then you squidge down the edges like this. And then you trim them up so that it's nice and tidy. And then you say, please move. You can wash over the top of that.
So they don't need Coban or anything?
Please dry it thoroughly, and that's it. We did do it. We did a study back in about 1995 in which we thought Fix-A-Mole, particularly gloves of Fix-A-Mole, would actually help people with swelling.
Yep.
And it made no difference. Whether they had a Gelinet and gauze dressing or a Fix-A-Mole glove, the swelling was the same.
Yep.
So it probably won't necessarily help the swelling as in like a Coban assists to reduce edema.
Yep.
But what it will do is because you've got full range of movement, you'll get muscle pump that will reduce the swelling in the digit. And that's really important. Full range of movement, good muscle pump, activities of daily living.
Could I get you both to talk about caring for post-surgical skin grafts? And I think we've got some video and some photographs.
I mean, that's really, I guess it's, you tend to get them at the late stage, you know, the graft has already been done, the first dressing has often been done by the dressing clinic.
Yep.
And this is at the later stage, and there's a great danger of putting too much emollient on, particularly in elderly patients, and then you've got a great thick layer of emollient. And,
so that's really, you're not scraping
really
off
claggy.
dead skin in this video, are you?
No,
You're actually scraping off emollient.
And you can see all the emollient on the forceps. And the other thing is, at this stage, once you've got to 10, 11 days, the graft is either taken or it hasn't. And if you've got bits of crust and what have you, trim them away. You also don't want to pick up things and cut that makes everything bleed, but there's little bits of dead skin, little bits of blood and what have you. Clean those away. And with patients who've got leg ulcers and those sorts of things, I know one of your things, Beth, get them to bring their own bucket. Literally, you know, sort of $2 store.
Now,
and
Stuart,
let's give it a good
it's
scrub.
rural Perth. They don't need to bring their own bucket. We can afford one.
Yeah.
The health budget is a bit
WA
healthier.
Country Health Services, Beth, and they probably
Bring your own bucket, people. Bring your own bucket. Bring your own bucket. Did you want to look also, following on from that, at the slide that we've got of the gentleman with the skin graft on his scalp?
I'll let you talk about that.
Yeah.
This is your slide.
Because the graft is really 90% taken, but it's just got that crusty edge to it. Because it's so dry and crusted, the graft will actually die, and your chances of it being infected increase. So what we need to do from a nursing perspective is to keep it supple. So we're going to go with emollient for something really high-tech. And if we can't get that, we're going to go down to Coles and buy some nice Vaseline and use that instead. And we're going to get him to wash his hair every day if possible. And not everyone will get in the shower every day.
He doesn't have a lot left
that.
to wash, but
He
I
doesn't.
take your point.
Yeah. Wash his scalp every day with the bits of hair.
Now,
Normal shampoo, normal conditioner.
The rest of that graft looks okay, or is that
It
just
is.
my... That
No, it
is
is.
fine?
It is.
It's only just the edge
It's
that's
just the
crusted.
edge.
Yeah,
Okay.
and considering that that's a gentleman's scalp, that's a beautiful word.
But as you say,
Yeah,
unless
'cause
that is
scalps are
looked
hard.
after, that edge is sorted out, the entire graft could fail?
You could get an infection in it, which could become very problematic, yes, and you could lose more if you graft. But we want this wound to progress positively. And the best way is good hygiene and keep it supple.
And what about scarring? Is the scarring going to be determined by the quality of the treatment of this wound?
Scarring is determined often by the type of surgical, the trauma, type of surgical repair, but most importantly, time to heal.
Yes.
So if you can heal a wound within 10 to 14 days from the time it's occurred, you will have, I think, about a quarter of the chance of it causing a problematic scar as if it's over the 14 to 21 day mark. But there are lots of other factors that impact on scars as well. So Stewart and I are not going to scar as badly as some because we're a little bit older. And they're saying now that there's good research coming out. It's all right, darling. Don't you get excited?
This has come up.
There's good research coming out that says categorically that older people don't scar as much as young people do. We know that
you've got to have something to look forward to.
Yeah.
Yeah, people with darker skins. That's they are for something.
Yeah.
People with very dark skin and very pale skin scar more readily. Pregnant ladies and teenagers scar more readily, and that's due to hormone imbalance. So there are lots of factors impacting, but we as health professionals, we can really impact by making sure this wound doesn't get compromised in any way and heals as quickly as possible.
Now, we did have a chat with Sharyn Kerr from Royal Perth Hospital about the rehabilitation of hand injuries and accessing plastics telehealth support services. Have a look.
One of the common problems, I think, with hand injuries is misdiagnosis at the beginning. So where it might seem like it's a simple hand injury and people are just assuming that it will get better with time, so they might strap it up, buddy it to the next finger, and then 2 or 3 weeks later realise that it's not moving properly and that there was actually a tendon or a fracture that got missed from the beginning, and you've already missed a few vital weeks in terms of treating it. The thing that immediately comes to mind is a very common, very simple mallet injury where the tendon comes away from the distal phalanx either with a bit of bone or just a tendon rupture. And the difference is if you can treat it immediately and it's immobilised for 6 weeks in the correct position and people are putting their splint on and off properly, that it's a relatively straightforward situation. Whereas when you're looking 2, 3, 4 weeks down the track, the ability to regain full movement and have a fully moving finger after that just gets less and less. The diagnosis might have been made properly at the beginning, and then a splint or a plaster is made, but the position isn't correct. So you're ending up with long-term problems of having to regain movement because of poor positioning. For a very simple hand fracture, such as a 5th metacarpal fracture, the metacarpals are meant to be positioned in at least 40 degrees flexion. If they are positioned at 0 degrees and a person is sitting in a plaster for the 4 to 6 weeks in that position, the ability to regain 90 degrees flexion at the end is reduced. And then you're actually having to have a lot of hand therapy to regain movement, as opposed to being able to come out of the plaster and start moving fairly well straight away.
And you can use your hand for things around the house.
In terms of knowing when to start exercises, it's very difficult to give a definitive yes, you start here, because it will depend on what their initial injury was and at what point you're seeing them. So if it's been a wrist fracture and they're coming out of their cast, then yes, you would start what we call active movement straight away, but you would be saying no stretches around a fracture site for another at least 2 weeks. It's just what your muscles will let you do. And we generally will say to people that they can start doing light everyday activity. And obviously if there's heavy work involved or resistance, or heavy gardening or heavy childcare, you would need to take that into account and advise them about that. But at 6 weeks for a fracture, you wouldn't want to be doing any heavy resistive work. It's light only and what your muscles will let you do. In terms of getting fingers moving, again, it depends on what the initial injury was, how severe it was, what levels of swelling there is. But when it's just been a simple injury, it's gone according to plan, and now you're needing to say to your patient, okay, you need to get it moving, then we have some very simple, we call tendon gliding exercises, which start up straight, ask them to make a hook, ask them to straighten up, ask them to make a duck bill, ask them to straighten up, ask them to make a flat fist and then to straighten up, and then a full fist and then to straighten up. And what we're doing is getting all of the IP joints to move through their full range, and also to have all the tendons gliding through all of their motions as well. So assuming that it's been a relatively simple finger injury, or they've been in a cast or in a plaster for, say, a distal radius fracture, they've come out, this is the time when you're saying, okay, go away, start getting your fingers moving, and then when you get them back, you can see how far they've progressed to see if there's a specific area where there's a problem that's going to need something further. And then the other one is just, you know, pretty self-explanatory, that they get their wrist moving, waving side to side, and moving backwards and forwards, and then supination and pronation.
Just bend right the tip of your finger for me.
In the rural setting, in terms of being able to deliver a really good quality of service for hand injuries, I think the most important part is the communication with the specialists, with the doctors in terms of the initial diagnosis, either by telephone or by the telehealth service, which you can link into, and then after that in terms of what therapy is required. And obviously, depending on what the diagnosis is and how complicated that rehab is, will depend on how well that can translate into the rural setting when there isn't a specific hand therapist to promote the right types of rehab. I think there's always communication open, and that's the first part, that if you don't know exactly when a person's meant to move or how they're meant to move or what the specific precautions are, that you can easily find out those things at the beginning and then pass that on to the patient so that they know exactly what they can and can't do, which will then facilitate what happens after their initial immobilisation, for example, happens. If they've been doing the right thing from the beginning, then that will be easier to get moving later on.
Put your arm here for us, so is it too hard?
Here, we don't mind being contacted about anything. If you've got any concerns that it's not going to be straightforward and that you've got a little bit of doubt as to whether you can manage it easily, then it's just a phone call. We can manage to look at x-rays, we can get them online, we can look them up. It's easy either for the hand therapist or the nurse to get in contact with another doctor, either the reg or the consultant if required, to have a look at x-rays and just to pass a look over it to say, yep, that's fine to go with, for example, conservative management, or no, there's a little bit of doubt about it, get them to Perth and we'll assess them for surgery.
And thank you to Sharyn and the team down at Royal Perth Hospital for having us. So let's continue the discussion on hands. Again, I see that Stewart has brought in some bits and pieces that look very technical in nature.
Well, I'm hoping that they're not too technical, because one of the things I find really difficult about patients with hand injuries is that splinting fingers is such a coward thing to do. And usually the hospitals just have the padded, you know, aluminium foam, and it's, you know, it sticks out everywhere and we're not too sure how to use it. So perhaps you could go through some practical splinting.
Yeah, I mean, splinting really is divided into splinting to immobilise and sort of stop everything moving. Splinting to rest, when you're transporting a patient who's had a hand injury, and when you do that, you want to put them into the what's called the intrinsic plus position, where the hand is bent down as close to 90 as you can get at the MCPs, with the interphalangeal joint straight, and then your wrist extended, so your finger's pretty much in line with your forearm, so that the hand rests like that.
So it's where there is no pressure on any part of the hand, it's a neutral position
well,
for the hand.
Well, it's a position where these MCP joints, when they go, the hand, when it's left, if it's swollen, tends to go into this sort of position with the MCP joint straight and the interphalangeal joints flexed. And it's jolly difficult then to get the MCPs to flex after a few days of being like that. and the interphalangeal joint's difficult to get them out straight. So by putting them, the MCPs flex, the interphalangeal joint straight, you then have the hand in a better position for hand therapy.
So if you had a patient, say, with a hand injury and you were transporting them and thought that they might not be operated for 24 hours, you might even put them in kind of a L-shaped back slab like that?
Yeah, with a wrist extended,
with a wrist extender,
back.
sorry.
And the reason for that is that if they get knocked, if they've got fractures, it's painful. Ditto if you've got cuts on the hand, and it just lets it rest in a comfortable position. If the hand does go stiff, then you're still in a position where you can at least have some function with it. But then the aluminium splints, you often sometimes see them wrapped right around the finger like this, so in case. And I'm really against that, because it doesn't allow the finger to expand. It doesn't allow any movement at all, and they're difficult to attach, and people then tend to sort of wrap them on quite tightly. So they're actually squashing the finger, which is not a good thing. The patients who've got what's called a volar plate injury, the finger's been forced back, and the proximal interphalangeal joint's been forced back. Often in cricket football, the finger is pushed back like this.
Yep.
And when they've dislocated, they get this as well. And as long as there isn't a fracture there, or anything more than a little flake fracture, you want them to mobilise like this, but not to go too straight. And so you can make up a piece of this which sits on the finger like that, and it's taped on here. You'd obviously cut it off at this point, but they can bend down, but it doesn't allow them to go straighter than about 30 or 40 degrees.
So you're not looking for total immobility?
No. You actually want to keep this joint moving, the PIP joint, into flexion, but you don't want it to go straight, because if it goes out straight like this, then you're pulling on what's been injured before. Right. And so there is a danger in the long term of the volar plate that where it's been torn apart, you can get scarring underneath the plate, and in the long term, it flexes down, and you get what's called a pseudo-boutonniere deformity, described by a guy called McHugh, Australian surgeon. First off, you concentrate on getting flexion, and then at a later date, you work on getting the extension. So when your hand therapist will do that for you.
When you're attaching that splint, you put a tape around the proximal phalanx?
No,
and then
you put a tape around middle and distal phalanx, and you leave that to bend up. Now, it's obviously difficult, and it's awkward for the patient. And all of these splints are. The mallet finger splints are awkward. You have to wear them for 6-8 weeks maybe. They get manky. You know, they're awful.
But let me get this straight. Are you you are looking for this movement, or you're allowing this movement?
You're trying to actively encourage it.
Actively encourage it.
So you want to encourage movement of the PIP joint, provided the joint is stable. If every time you move it, it dislocates, then you'd certainly want to keep it splinted and not move it at all. But in the vast majority of cases, even where the whole joint's been dislocated out and relocated, you can then get them moving again.
Yeah. Now, Stuart, you've got another one with a little kink in it.
Yeah.
What have you used that for?
That's the Mexican hat splint. When you make a mallet splint, one of the problems is when you push your finger back like this, if you look at it on yourself, you see the skin here goes pale.
Yeah.
And so that's because you're not getting as much blood supply and the skin's being scrunched up.
Yeah.
And so when you put a mallet splint on, you don't really want something resting on it, because you're adding pressure to this already devascularizing attitude.
Just remind me about mallet fingers.
Mallet fingers where you've stubbed it against something usually, and the end tendon, the common extensor tendon at the tip here, has snapped off.
Yep.
It's different from the mallet fracture, which is an end-on, again, footy and cricket injury, where the end distal phalanx is smashed against the middle phalanx, and it breaks a bit of bone off.
Sort of acts like a chisel and then pops up through the tendon, yeah?
Yeah. Well, here it just pops the bit of the tendon off and it's carried on. You see the little fragment up here, and the fragment comes off that way, and then sometimes this bit subluxes down, and that's particularly bad. But what you're wanting to do is to hold this bit slightly extended, and so you create a splint that does that. And what I do is I actually extend it like this beyond, because when you put your fingers straight, a lot of people, when they put their fingers straight, you see mine goes up a little bit at the end there. Yeah. And what's happening is your central slip, your extensor tendon that inserts into the base of the middle phalanx, is pulling like this. Your lateral bands coming along here overextend that. And there's a ligament here, Lansmeyer's oblique ligament, which also comes up. When this goes straight, that extends the distal phalanx. And you see that in the diagram, that when you do this, your extensor tendons pull forward, these relax. And so you're trying to get the ends of the tendon here to come together. And by doing that, you stop them from pulling apart. And so I put them into a splint like that, with this cut off there.
And the end.
This is held still, and again, that comes up. I put them in that for 3 weeks.
So once again,
and then
you've got your taping on the distal and the middle phalanx.
Distal and middle phalanx, not the other one.
And then the other one just tilts up and down like a little lever.
And that way, actually, they can use this bit because they can feel it.
It's a real nuisance putting that thing in your pocket because then it
surely
flares when it comes out.
It's one way to stop yourself from spending on the credit card.
And then well, I guess, you get it in both hands, you're in real trouble. Try going to the lavvy. The other thing that we talk about sometimes is buddy taping.
Yeah.
And you can use it just with ordinary tape. You can put it around. These are ones that have been made up by the hand therapists, and they're just Velcro, and they're bits of Velcro, and you can put them on like this, and then wrap this round, tighten it up like that, and it helps to keep the fingers together. You'd normally put one on here, one on there, so that the two fingers move. We've got a fracture in the finger, and there's a danger of rotation. By keeping these two together, the good finger keeps the other one in alignment and stops it curving underneath. On the little finger, though, you've got a problem, because when your hand is like this, those two are oblique like that, and that's even more oblique. But when you make a fist and it's bent round, you see that these two line up. And so as you do this, it changes.
It's a design feature.
Yeah, absolutely. But they've got a very dinky little splint, which they put on, and this bit goes on here, that bit goes on there, like that, and then when you bend round, it stays in alignment.
Okay, now if we were trying to construct that out of the bits that we can find in our emergency departments...
You wouldn't be able to.
It's a little piece of pop stick and two sticky tapes.
In fact, you can, because you can take one bit of, have a bigger bit of elastoplast, put one round this way, one round the other way, and then you just have to cover the sticky bit over with a bit more there. But it
so you
keeps
could cobble
it
together something. But as you said, these were made by a hand therapist.
Yes. So your local hand therapist may well be able to create something like that.
They're plentiful in the bush, aren't they?
Oh, very
plentiful. Everywhere.
Well, good physiotherapists.
Local, the physios and occupational therapy departments
and
should
if
have
they're
some bits of
uncertain
Velcro
about
somewhere.
it, they just give a ring to Royal Perth Fremantle Hand Therapy Department. They'll give them instructions on what to do.
Could we move on to some other types of wounds? And
by all means,
the things that looking at hands, the one thing that comes to my mind is cat bites and fingers, and animal bites in general.
Animal bites,
and of course they present very commonly to rural hospital emergency departments. And when we're not talking about snake bites, but about other animal bites, do you repair or not repair? Do you oral antibiotic or intravenous? Thoughts?
Cat bites are particularly bad. There was a Dutch survey that I was reading about the other day. Something like 60% of cat bites to the hand became badly infected. And they would come up within 3 hours. It's really quite dramatic. Mostly it's Pastorella species.
Not a good reason to get rid of cats, really.
But they don't all bite. And, but I think you have to be particularly wary of them. And if necessary, you need to bring patients in, intravenous antibiotics. It really depends how they react. But I think with cat bites, I would say certainly oral antibiotics is a prophylaxis. And
Pastorella is mostly covered by penicillin-based drugs?
Yeah, Augmentin. And if they can't take Augmentin, then Cipro. And
do you have to cover them for anaerobes as well?
Sorry, clindamycin. And that usually covers that. Most of the Pastorella species are sensitive to Augmentin, but you need a fairly good dose of them, good whack of them. So, you know, not the sort of normal 250, you need at least 500 or a gram.
Yep. So big doses
750.
elevate, rest
Yeah.
and...
Yeah, absolutely.
How do you clean out a cat bite? You know how they, or even a dog bite, you know how they've got the little V-shaped tooth? Do you have to kind of get something in there and irrigate, or do you lay it open? What do you do?
The ones that we get tend to be the ones that are really nicely infected. And I'd actually take those out and you cut round them and if necessary track them down. Because if you don't do that, they often keep on going.
Yeah, good old-fashioned peroxide not in use at all?
Sadly not.
It made such a nice fizz. Beth is looking absolutely horrified.
I'm horrified by that.
No, WA Country Health Service have taken it away completely, so it doesn't exist. It does in the plastic dressings clinic at Royal Perth. I'm surprised that you don't have it at Fremantle, but and very, very effective with your, you know, superficial partial thickness skin loss, skin grafts, crusty, whatever, very useful. That's why we've not
As long as you wash it off with lots of saline afterwards.
Lots of good try running water, even tap water. If you can drink it, you can wash in it. So yeah, we don't have any problems, but I know WA Country Health Service have definitely taken it right off every shelf in there.
You do have to be careful with it, and you don't want to use it in cavities.
You do.
There is a risk of, you know, pressure building up, that sort of thing.
So a dog bite is a different prospect?
Dog bites aren't so bad. Cat bites are the worst. Human bites next. They've got some really nasty organs. The classic one is the punch. Yeah, you know, the punch comes here and it goes onto the tooth. The tooth here, and the problem is it goes through the tendon, through the skin, through the tendon, takes a chip out of the head of the metacarpal, and of course you can then get infection into the bone. But when the patient presents, their hand is like that. So the tendon has moved back here, the skin has moved back even further, and the joint has been closed over. So you look in, you think, oh, it's only a skin laceration, tendon's not damaged. So the trick is you must examine in the position that the injury occurred, and then you see the injury going right the way down. Usually
they've passed out for 24 hours. The hand is about this big, and it's an injury that I call acute pussy knuckle.
Yeah. That's a technical term.
That's a technical term.
It's very descriptive. Nothing else.
And those ones require surgical laying open, Stewart?
Yeah, I think so. You know, you need to check to make sure there isn't a chunk of stuff out of the bone.
And then you would treat it as a septic arthritis.
Absolutely. And take it back to theatre 24, 48 hours later as you need to, because if there's pus in the joint, you want to wash it out, put them on IV antibiotics, and then bring them back again later, check, and keep doing that until the pus has stopped.
Any other animals that are particular that need to be watched out for? Okay, cats are the worst. We've always known that. No redeeming features at all with cats, okay? Humans next, and of course that's the stuff that we carry in our mouths. Then dogs. What about other animals? What about things like cattle or sheep or anything like that?
Horses and camels.
Horses.
Because it crushes and tears. And a horse is a very powerful animal. So you see those.
And Beth's got a picture of a dog bite there.
I have,
which went into both sides of the patient's shin.
Yeah, a little old lady taking a walk and a little terrier-type dog grabbed her. And that's why it was both sides, the shin, little mouth of dog, little leg of lady, and grabbed and wouldn't let go.
So with that sort of thing, again, you're looking at that same kind of crush injury that you're talking about with the horse bite, although...
Dogs often worry as well, you know, they shake. And so it tears the tissue as well as crushing it.
So when you're debriding that kind of wound, initially in the emergency department, what sort of things are you doing and looking for?
You're really trying to give it a good wash, get it really as clean as you can. I don't think at that stage you want to... If there's obviously dead tissue, then yeah, I'd take it away. But I think really with dog bites, it's much more to give it a really good clean out. And then keep the wounds. If you've got some tendon exposed or something, you might put a little tacking stitch to hold the skin over that. But you want to do as little stitching as possible at that stage. Do a delayed primary closure once everything has settled down.
I don't know if this is on your list, but it's been on my mind for about 10 minutes. Lately in Perth, we have seen a number of awful incidents in pubs at night, glassings.
Yeah.
Glassings. These wounds, when we see them on television, look absolutely horrible. Any sort of top-of-mind lessons, if GPs are presented with this in the bush, far away from specialist care, for instance, what are some of the things they might need to look out for?
Glass is really bad stuff. Glass keeps going until it reaches bone, and sometimes it goes into bone. Certainly in the hand, something like 60% of injuries, glass injuries, are underestimated even by specialist hand surgeons, the amount of damage that's been done. So I'm very, very wary of glass injuries. And I think always examine the patient very, very carefully, look for nerve dysfunction, those sorts of things. And you've got to be careful when you explore them to make sure all the glass is out.
I know that, you know, windscreen glass is usually sufficiently radio opaque that you can at least see the little bits. What about bar glasses? Can you see them on X-ray?
Not always. I mean, the big beer glasses, they've got a bit more lead in them, you can, but the thinner ones tend not to have.
Okay.
And, I mean, they will eventually come out, but I think you've got to be careful when you go exploring the wounds. Be wary of sticking your fingers in, because you'll cut yourself. And you know, often gently moving a forceps around, you'll hear it clinking against it.
Yeah. Just before we wind up, could we just talk briefly, having mentioned bites, about things that take divots out of ears or noses? So we've actually got like a chunk of tissue that's been removed. Well, because, you know, patients come in with something that looks dirty and they've got a horrible laceration on, say, the edge of their nostril. How do you deal with that? Does that need kind of immediate primary reconstruction, or do you leave it
or some sort of
for a while?
polyfiller or whatever?
Yeah. How do you fill up the divot?
But I mean, yes. I mean, I think really the thing to do, if they're bites, you treat them like bites, and I mean, you just clean it up, really good wash, what have you, get it clean, and then if there's cartilage exposed, which in both the nose and the ear, you've got skin then cartilage, you want to try and cover that over. But I think at that stage, because your reconstructions are often complex, you don't want to risk the possibility of infection. And certainly there's a little diagram I've done of, you can take a little bit of the ear, because the edge of the top edge of the ear is very much like the edge of the nostril. You can actually take that as a composite graft and put it in.
You mean with the cartilage as well?
With the cartilage, with the skin. And that's a sort of, you know, you've got a divot out of the nose like this. Once it's all settled down, it will scar and pull in. And so you have to reconstruct the original defect. And then you can take a little wedge out the top of the ear, close that together, and then use that as a composite graft to sew in.
The colour is invariably different, isn't it, Stuart?
It's not too bad in terms of colour, because they've both been exposed to the sun, and it's very similar.
And will it always retain the colour of the original, the ear, for instance? If
Yes,
you
it will.
Okay.
But I mean, when you're doing wolf grafts, when you're doing full thickness skin grafts on the face, you tend to take it from behind the ear or on the neck in an area that hasn't been. And they match really well, actually.
Yeah.
But you wouldn't do that until you were absolutely 100% that there was no chance that there was any trauma left, any swelling left, any infection left.
That's quite correct. I mean, I'd wait probably 3-6 months. Let it settle down.
Okay.
And I mean, if necessary, you put a prosthesis over the top of it, or Beth will construct your nose.
I will.
Nose or a dressing.
Good like that. Just to say that one of the things that you can tell your patients to do is to sit up on a few pillows at night. One of the glassing fellows, we did a video conference with him while he was giving his TV interview. We knew that he'd be coming back to us. And when he came back to us 2 days later, the residents said, he is so swollen. And we said, well, actually, he's not, because when he was on the telly, he was a lot more swollen than that. What they don't tell them is to sit up at night. And people lie on one pillow. So as you lie down at night, your face gets swollen. Sit up during the day and it reduces the swelling. So tell them when you're doing your little stitching up, sit up at night, a couple of pillows, and wash. Clean yourself up. Don't be frightened to get into the shower.
You put the pillows behind you, not underneath you.
Oh, yeah, behind you.
Okay, so in other words, you sleep in the upright position.
Sorry, was I...
No, you said on pillows, but I know what you meant.
Those of us who travel Qantas frequently are well practised in that art.
Well, there you go. Well, it'll help the swelling in your face if ever you have facial trauma or facial surgery.
Good tip. Well, in our final segment tonight, we speak to the team at WoundsWest about the education and support services they provide GPs and health professionals for the management of wounds.
WoundsWest is a statewide project, and the aim of the project is to improve the delivery of wound management services within Western Australia. From your point of view, as a general practitioner, we have a number of services that we can offer. Primarily the WoundsWest Advisory Service, which is a telephone-based advisory service supported by an information technology platform.
Well, the WoundsWest Advisory Service can assist you with providing a comprehensive assessment for the patient and then giving suggestions for management. And that may include further diagnostic investigations the patient may require to determine the causative factors of the wound. And the comprehensive assessment will assist in identifying factors that may inhibit healing and that may well be contributing to the delayed healing of your patient's wound. We have an IT platform with MMNEX, which is a web-based program, and it allows for you to provide information and upload digital images of your patient's wound. And the information that you provide will enable myself or one of the other WoundsWest consultants to complete a comprehensive assessment for your patient and be able to develop a management plan from that to assist you in your patient's management. To upload the images, it's just a matter of adding document, and then you can go click on browse and go through your PC and identify where the patient's pictures are held, and they will then upload into the system. This program also allows you to graph your wounds. So from the information that's provided when we calibrate and draw the size of the wounds and the different tissues within the wound, it provides you with a graph so you can clearly see the progress that's been made with your patient's wound. The patients with wounds that we have managed so far, we've had excellent results with, and over 70% of the patients that we've been providing services for have resulted in a healed wound. And for those patients, they've had a very comprehensive assessment not only in relation to the wound, but in relation to their general health. And management has been provided for other factors in relation to their general health that could be delaying any wound healing, so that we can overcome them barriers and get the best possible outcome for the patient.
Generally speaking, we say that if it is an acute wound and if there has been no healing within 2 to 3 weeks, then it would be ideal to send the referral through to us to see whether or not we can assist. Certainly with chronic wounds, then if the wound has not healed within a 3-month period, so we are looking at pressure ulcers, at leg ulcers, then we certainly would like to have the opportunity to assist yourself and your team. So we have access to a wide range of specialties, people such as Fiona Woods from a burns perspective. We have access to podiatrists, we have access to people who specialise in pain relief or palliative care. So we have a very broad network that we are able to tap into to assist yourself as a doctor to be able to maintain your patient as comfortably as possible in their own home environment. We have a wonderful education program that can be accessed by anybody, anywhere, at any time. They are endorsed by the Royal College of Nursing Australia, and recently we were invited by the Royal Australian College of General Practitioners to develop a specific GP portal that has ALM recognition and achieves 40 points for each of the modules that are undertaken.
That portal is available on the Royal Australian College of General Practitioner website, so they can go to the website and they'll find the link there, and then it will take them into the program.
People can test their knowledge of their wounds in the first instance and see how they are travelling. otherwise they can actually start to work systematically through the modules.
The first module is the core module, which is our foundations and principles of wound assessment and management. We then have 16 modules being developed, but 5 others are available online. We've got the pressure ulcer module, which covers prevention and management of pressure ulcers. We have the foot ulcer module, which is looking at the high-risk foot, very important in our rural and remote area. We have the leg ulcer module, which is focusing on the major disease processes for leg wounds. We have the skin tear module, which is looking at skin tears predominantly in the elderly. And we have the burns module, which is focusing on burn wounds and immediate management. That module is going to be expanded, but at the moment it's looking at emergency management procedures. So very important for GPs. If you're out and you have a patient that comes in with who sustained a burn, it goes through the process of managing that, cooling the burn, warming the patient, and then getting them referred on when necessary, or managing them in the emergency period. We also provide face-to-face education. So quite often we'll come out to the GPs and provide you with lower limb assessment, and we can take you through the competency of doing Doppler assessment, monofilament testing for sensory nerve assessment, etc., so that you're getting the skills that you require, and also talking about the interdisciplinary approach with podiatrists, for example, for that referral process.
So our whole aim is to improve patient care, to improve the well-being of the community by using a health promotion approach for those people who are currently asymptomatic and keep them that way. But if they do develop a wound, then what is it that we can do in assisting all persons who come into contact with that person with a wound to actually provide the best possible care. And at the end of the day, to ensure that WA Health provides wound management services that are efficient, that are cost effective to both patients and the health service as a whole.
And thanks to everyone at WoundsWest for letting us know about your services. Now, Olga, I understand you want to get in a plug for a workshop, one of the many workshops you have created. What is this?
Well, this is a workshop at CTEC, which is created primarily for general practice nurses, and it's designed to talk them through assisting a GP who is doing procedures. So it talks about treatment room setup. We've got some practical tips for restraining wriggling little children. They will get a chance to play with histoacryl glue.
How long is the workshop?
It's a one-day workshop. It's the day after Melbourne Cup, so Wednesday the 3rd of November.
3rd of November.
And the GPs are welcome and in fact encouraged to come along for just, I think, an hour and a half of the workshop, so that their practice nurse that they're paying for can practice assisting them in whatever procedure they would like to have a go at.
And I guess because doctors' techniques vary from doctor to doctor, so that practice nurse will get to know the peculiarities of her own particular doctor.
That's the whole general idea. It also means that we will have some surgical tutors there who are specifically there to assist the GPs if they want to revise, for instance, maybe not putting bits of ears into people's noses, but something perhaps a little less complicated.
Removing BCCs from behind ears, perhaps?
Yes, that'll be it.
Okay. And CPD points for nurses?
CPD points are being sought for the nursing staff and should be up and running by the time we get the course on.
How many places do you have available?
I think there's about a dozen.
Thanks for that.
Super.
You're very entrepreneurial, aren't you, developing all these workshops. Final take-home message from Stewart and Beth. Top of mind stuff for our GPs, that one of those little maxims that they can carry around with them and never go wrong.
Hands are meant to move. Keep them moving.
Good idea. Beth?
Don't be frightened to wash it.
Okay, there you go. Good hygiene message. And now remember, this programme and any of our programmes going way back to 2008 are available to you on our website at ruralhealthwest.com.au. We're back for our final programme of 2010 on November 2nd. That's Melbourne Cup Day, which will focus on mental health. So thank you for joining us. I'm Jerry Gannon. On behalf of Olga Ward, Stewart and Beth and everybody here, thanks for being with us.